Hospitals are cornerstones of their communities, serving as principal access points to care for the nearly 60 million people, or 20% of Americans, who live in rural areas. Despite their importance, rural hospitals continuously confront a multitude of challenges that threaten their ability to ensure local access to care. Welcome to Advancing Health, a podcast brought to you by the American Hospital Association. I'm Tom Hedderly, senior writer for AHA. Recently, AHA published a rural report titled Challenges Facing Rural Communities and the Roadmap to Ensure Local Access and High-Quality, Affordable Care. This podcast series is built around the rural report, meaning it highlights a rural health challenge and shows how the field responds to the call to action. For this podcast, our focus is on workforce, one of the greatest challenges confronting rural hospitals.
Hello, this is John Supplitt, and I'm Senior Director of Rural Health Services at the American Hospital Association. And with me today are two authorities in rural healthcare who have established a nationally regarded and highly effective community health worker program in northeastern Vermont. Sean Tester is CEO of Northeastern Vermont Regional Hospital in St. Johnsbury. In addition to his hospital experience, Sean previously was Executive Director of Northern Counties Healthcare, a federally qualified community health center with 5 medical and 3 dental practices and a home health and hospice division. Also with us is Laurel Ruggles, who's Vice President of Marketing and Community Health Improvement at Northeastern Vermont Regional Hospital. Laurel has over 20 years' experience in healthcare administration, marketing, and community health. She has been the project manager for the St. Johnsbury Blueprint for Health since 2005 and is the architect of their local community health team. But first, let's review the challenge. Insufficient access to primary care and other essential services leads to poorer health outcomes and increases the likelihood of more costly, higher acuity episodes at the time of treatment. Moreover, limited transportation options in rural areas limit access, contributing to delayed or even foregone medical attention and subsequent disease progression. Sean, are community health workers a solution to the workforce and access issues in rural America?
You know, John, I think they are an important tool in our war chest. They certainly can be. Studies have shown that implementing a community health worker program is the solution that delivers meaningful and measurable results to hospitals and health systems. You know, the research has shown us that these types of programs can result in average savings of over $2,200 per patient served, and hospitals can save over $2 for every dollar it invests in a community health worker program, all while improving health outcomes of patients and their communities.
Well, those are meaningful numbers without a doubt, Sean. But tell us then, how did the community health worker program at Northeastern Vermont Regional Hospital come about?
So hi, John, this is Laurel. So right around 2002, at the request of our physicians, NVRH engaged community health workers to assist in helping our patients do things like secure food, transportation, housing, advanced life skills to improve their health and well-being. We called it the Community Connections Program, or COCO for short. So COCO really gained traction in 2007 as part of the Vermont Blueprint for Health. The blueprint calls for advanced primary care practices to serve as medical homes with comprehensive support from community health teams and an integrated information technology infrastructure. So COCO fit right into the blueprint perfectly.
That's fascinating. So you've really been at this for approximately 17 years and got a major bump when it was part of the Vermont Blueprint for Health.
That's right.
Well, then what happened?
Well, you know, I think our experience here really validated the value of the COCO model, and it ultimately became the cornerstone for the Blueprint for Health and community health teams throughout the state of Vermont. What we were able to do with our community health workers was really intentionally integrate them into the entire care team. So that care team already included the physicians, the nurses, behavioral health specialists, chronic care coordinators, dietitians, and all the other healthcare professionals who we wrap around the patient to provide the exceptional support.
That sounds interesting. So tell me more about the Community Connections team.
Sure. So the MVRH Community Connections team consists of 5 full-time community health workers, a supervisor, and myself. So these community health workers are knowledgeable about resources in our area, and they also receive additional training to help the people that they serve get access to social and economic services to improve their life conditions. The community health workers do not function independently, but rather they work with the entire team, and the entire team works to address the goals and wishes of the patient, with the patient really at the center of the team.
So kind of like a primary care, a community health model.
For sure, yes.
So practically speaking then, how does this work?
Sure. So the COCO program office is open Monday through Friday during regular business hours. Some of the clients are referred right from the medical homes, from the physicians. They come from other area agencies, but you don't need to have an appointment, and walk-ins are certainly welcome. So the community health workers interview anyone who comes through the door about their access to a primary care physician and also whatever social determinants of health that they might require. And clients are asked to prioritize their health, social, and human services need, and they use things that we call like patient engagement tools, like the Camden cards, which are really a deck of cards with pictures of common health and social needs on them. And it's really a visual way for people to help prioritize what their top 3 concerns are. The community health workers will report their findings back to the entire health team, and then the team will come together along with the patient and any family or friends and develop a plan of care.
Fascinating. So then how is this plan of care implemented?
So the community health workers meet individually with each person, and they link them to community services such as the food pantries or programs to help with heating assistance during the winter, or even things like legal aid if that's what they need. They also help people enroll in Vermont's health insurance program. They can help them gain access to a primary care provider if they don't have one. And they can also do things like arrange for transportation to medical appointments. So once the conditions affecting this person's life are stabilized, the community health workers continue to work with them to help them increase their own skills in managing their health conditions, and then also to help motivate them to engage in healthy behaviors to keep them healthy and well.
Very good. So, Sean, you've been at this for many years now. Do you have a sense of what the cost associated with the program is?
Yeah, actually, we've got some great data on that, partially because of our participation in the Vermont Blueprint for Health. We were actually part of a study that analyzed the cost of our community health worker program that was published by the Journal of Community Health recently. The study showed that the estimated total program cost was about $420,000 annually. About $285,000 of that was in direct personnel and staff costs, with the balance for operations.
So in addition, the hospital also helps fund the Community Connections program, and then we get the funding through the government and private third-party payers through the Vermont Blueprint for Health, and they are legislatively mandated to help support the community health teams in the state. And we also receive additional assistance from the community itself. They provide what we call an unmet needs fund, so we can help meet some of the needs of some of the clients of Community Connections. And the unmet needs fund is supported by local community banks and other private donations.
So this is more than just a hospital initiative. This sounds like a much broader community-oriented initiative that involves both public and private partnerships. Is that correct?
Yes, that's what makes it, I think, kind of unique.
Yep. I think it's important to recognize that we've been at this so long, and it is so embedded in how we care for our patients and community that all our community partners have bought into it and have embraced the model in such a way that makes it incredibly impactful for our patients.
Where would you instruct our listeners to begin? If they were to attempt something like this from the grassroots up, how would you recommend they start?
Boy, that's a tough question. I think one of the beauties of the Vermont Blueprint for Health is that each one of our communities was allowed to really design our own community health team based on the needs of the people who live here and also what kinds of resources that we had. So I think I would start by looking at what your needs are. What do your patients need? What kind of service do they need? Do they need additional nurses? Do they need social workers? Or are there things that a community health worker or a team of community health workers could really help with?
You know, in a lot of ways, this role is a kind of like a quarterback on the team, right? Linking the patient to resources in the community that already exists. I would suggest starting with two things. Talk to your community partners about what the challenges they see facing connecting with patients. And then secondly, talk to your providers, because this initiative originally came from requests from our providers to help get their patients linked to the right resources in the community. And I think that because we responded to the providers' requests, that made the solution very powerful because our provider community bought into it so quickly. Wouldn't that be true, Laurel?
Yes, I would agree.
Did you draw upon your community health needs assessments at all?
Yes, for sure. We've been doing community health needs assessments for many years, quite a few years before they were required by the Affordable Care Act. And poverty is our number one health disparity here. And all of those, what I call the symptoms of poverty, which is food insecurity, transportation needs, housing needs, those are all things that this Community Connections program helps people with. And that's definitely what our community needs here.
Well, that's excellent. Thanks very much. I think that's a great place to start. You know, talk to your providers, listen to your physicians and clinicians, and cross-reference your community health needs assessment. So tell us then, with all this in mind, what's the return on your investment of the community health workers and the community health teams?
Yep. Listen, the data is pretty empirical on this. As part of the Blueprint for Health, the state analyzed the utilization patterns and costs, and they really found some significant decreases from one year to the next in hospital admissions and emergency department visits and their related per person per month costs. So for an example, inpatient use decreased by 21% per person per month, and costs decreased 22%. Another measure is looking at emergency department use, which declined 31%, and associated cost per person per month fell 36%. Overall use and cost per person per month dropped 8.9% and 11.6% respectively. But also, I think there is an intangible return on this investment as well. It really does help us start addressing the social determinants of health that many of our patients experience. And it really takes a lot of pressure off of our providers. I can't tell you some of the conversations that I would have had 10 years ago in other healthcare settings around, yeah, I'm supposed to keep my patient's hemoglobin A1C in check, but she just came in and she's getting a divorce and doesn't have the money for an attorney, or their house is in foreclosure, or they don't know where to get food for their family. This community health worker system gives our providers access to resources to help their patients address those issues so that the provider can focus on the health and health outcomes for that patient.
Yeah, that's so true, Sean, because as favorable as the economic impact has been on the healthcare system, more importantly, we've seen a significantly positive impact on our patients and also our population's health. So by meeting some of these basic needs, we have decreased patients' risk for sickness, established them in a medical home. It's improved their compliance with their treatment plan, and we've enabled them to return to work and enjoy a better quality of life. So, as Sean said, the physicians love us, employers love us, and most importantly, our patients love us.
Well, and I'm feeling the love too, Laurel. There's no better testimonial than that. I think we can agree that the community health workers and teams are a success for Northeastern Vermont Regional Hospital. And this was a great insight into the overall rural report and one of its most tenacious challenges and how the field is responding to this call to action. So thanks very much for listening, and thanks to Sean Tester and Laurel Ruggles for sharing their work, and to Talia Schmidt and Jordan Sarver for writing and production. And if you want to learn more about the work that the AHA is doing to improve access to care in rural communities, visit us at www.aha.org. I'm John Supplitt, and this has been Advancing Health, a podcast brought to you by the American Hospital Association.